I'm going to talk with you a little bit about applying psychology to problems in healthcare, especially particularly mental healthcare. And I want to do it for a couple of reasons. It's been my good fortune and challenge to work in healthcare. I was, as Dove said, at the Beth Israel Hospital for 20 years. And the fact is, people don't talk about mental health care. In a big healthcare setting, people don't talk about mental health care. If you look at if you're a sociologist or an anthropologist and you look at where the assets are, even in your own college, the science building at big time University Pickett, right in the middle of things, and it's huge, right? The school psychology program tucked in the corner someplace in the basement somewhere. So for us in thinking, Dr. Berman and some of the other faculty members and staff some years ago, it became important to think about how do we build a space to talk about the critically important issues related to mental health care. And instead of bringing people in who are going to fight with each other, because the APA is really good at that, American Psychological Association, if you're a counselor, as I was for many years before I got my doctorate, you don't belong to the APA. They tell you you're not good enough. Imagine that, right? From a business, what a great business model, right? So let's exclude a whole bunch of people and tell them they're not good enough, right? They're not good enough. Even though their research says the work that we all do is pretty much the same in terms of efficacy, right? In fact, I was talking to some folks downstairs from Albertus Magnus, and we were thinking about what makes a good clinician, which I've always felt is about compassion and relatedness, not so much about how are you with handling statistics. Kind of need to be smart enough to read the literature, and I'll give you a little bit of this. But what really makes the difference, the critical difference, is can you form a relationship with somebody? Can you care about their experience in some way? So our aim here is to try to create a space where we not only bring in all the different elements of people who are training to do work in mental health care, school psychologists, counseling psychologists, applied behavior analysts, all the folks that are doing the work, but we insist that they respect each other and they get along, because we'll keep saying, you know, the work that you do, really good, really good, no better than the work that you do, really good, but no better than the work that you do, really good, really good. Let's work together. Let's help each other to think about what we're doing so the leadership psychology people can come into the clinical people and help them to become prepared to lead when they need to lead, right? So in my business as a clinical psychologist, I've been the director of something since I was 32 years old, probably, and big things like a Harvard Teaching Hospital's psychology division. And I never took a course in that, you know? I didn't know anything about budgets for certain, and I didn't know much about managing people or leadership, right? So where we are, and I didn't know much about kids, right? So the school psychology people, the developmental side, all of the folks that we have make a space in that. And the other reason I wanted to present this a little bit to you is to say it's a broad field, psychology. We just had someone told me a really effective neuroscience lecture before this one. If you look at your departments, if you're a student and you see who's teaching what, a lot of people doing a lot of different things, but probably only one or two seeing patients and helping you to see patients and helping you to think about seeing patients. And so my job, having been a guy for 35 years or better that saw patients, is to say, this is really important work. So if you're a teacher, I hope even if you're teaching neuroscience, that it's something that you think about how you can present to students so that you can nurture their interest in this and not just offer them an opportunity to replicate who you are and what you've been if you're a neuroscientist, but you can understand that there's a crowd of folks that want to be in this space. And the second point I want to make is this space really needs us. This space really needs us. So I'm about to give you probably the grass top talk of an acre of grass, right? And to ask if you're a professor, dig in deeper with your students. Ask if you're a student, dig in deeper to this area. But what I wanted to do was to just be a little bit of an anthropologist and visit a whole bunch of different places to say there's a tremendous need in this country for people to get interested in applied mental health. 20% of adults have a diagnosable mental illness. What does that mean? That means people can't sleep, can't eat, are not motivated to do things in life that are important for them to do. They cry frequently. It means that they're so anxious they can't sit in a room, clever way, and pay attention like a child needs to be able to address information that comes, and it's worsening. So surveys show us that especially depression among teenagers is continuing to rise, not continuing to fail. We are in a fortunate space, thank you, President Obama, where people have more coverage for mental health. And thank you in Massachusetts to Ruth Balzer and a few other folks, right, that made sure that we had mental health parity, which means to younger people, if you've got heart disease, you've got your insurance, it'll cover you as long as you got heart disease. In the old days when Rick Parr and I were starting our work, you got 8 visits from Blue Cross Blue Shield, and that was it. That's all the coverage you had. And if you've got a generalized anxiety disorder, if you've got a major depression, 8 visits ain't going to cut it, right? You need to really engage. And if we're thinking what makes psychotherapy effective is the relationship, as I just said. You don't form a relationship in 8 visits. It's like speed dating, right? You can't do that in 8 visits. So we do have insurance coverage, but what we don't have is access to care. And the reason we don't have access to care is we don't have enough of you folks working in the field. That's the predominantly rate-limiting step for people. 56% of adults with mental illness don't seek care. Large numbers, I'll say again more about that in a bit, can't find care if they want to. If you're a person of color, you're going to see someone who looks like me. Most of the time, 90% of the time, you're going to see somebody who looks like me. And is that important to you, right, or not? Well, the book says that if you're a Spanish speaker, even if you meet somebody with Dr. Parr's experience, you're not going to come back half of the time. Because if you're not in the culture, you're going to miss something really important. And people will say, well, all this research on therapist-patient match isn't really definitive. Well, if 90% of your therapists and therefore your principal investigators, and therefore your likely people to be in these studies are white, non-Latino white, of course that literature needs nurturance and diversification and breadth. So that, I think, is the clinical issue for you folks, is can we begin to tailor the therapeutic alliance, the therapeutic relationship to see among the things that contribute to it is a match with race and ethnicity and background like the military. Does that really make a difference in terms of keeping people in treatment? There's a little bit of literature, as you may know, that says Asian people stay with Asian people longer than they stay with people that are not when they're able to make that match. We're doing a lot of work here with military mental health to see if that makes a difference, right? We've got money to pay for mental health care. People are stigmatized, so they don't tend to seek it, and they're frustrated, so they don't tend to obtain it. And yet, when it's not treated, it's really, really, really got consequences. So serious mental illness costs us $193 billion a year. Mood disorders are the 3rd most common cause of hospitalization for children. Adults with serious mental illness die 25 years before anybody else does. 25 years before anybody else does, just because you've got a chronic mental illness. 25 years off your life, right? 1/3 of students in special education drop out of school. The most common cause of high school dropouts is untreated anxiety and depression. So if you think about costs, right, people tend to look at the economics of this and they say, well, what's it cost to run a state hospital? What's it cost for Blue Cross to put this benefit in? But what's it cost our culture to have so many kids, especially poor kids, especially kids of color, flunk out of school? What does that do? Lost income on these folks that graduate not with a high school diploma, but maybe not even with a GED. They got 2 years of high school. What are they going to do for work? Who's going to hire those kids? How productive are they going to be? What kind of earnings are they going to have? And what are they going to pass on to their kids? Right? My dad was a cop, never went to college, but he had high school, and he knew what he didn't have, and he said, we can get this in the next generation. Go to school, and I'll help you go to school. If you've been frustrated, flunked out at the 10th grade, 9th grade, 11th grade, hard to sell that idea or that ideal to your kid. And then what happens to folks that have earnings less than they should have? They're a drain on the economy in a myriad of ways, right? A myriad of ways, from problems of of gangs and violence and poverty, right, to sickness and ill health. So there's a tremendous need for us to do this. And what you need to know is what your professors have told you is the good news in psychology is 7 times out of 10, we can help you if you can get people there, if you've got enough of the good people to be there. But 7 times out of 10, we have efficacious treatments. We've got efficacious people. We've got effective people, right? But the problem is we're not budgeting for that. We're not scheduling for that. We're not putting people in places. We're not encouraging people to move into the space and say, you know, our world needs you to do this sort of thing. Consequences, just a couple more. Homelessness, about third to a half of the people on the streets are people with treatable mental illness, right? So this is like, if we can get somebody into a space where they can get their meds and they can get a job and they can get help and they can get this, I mean, it's costly to do that, but how costly is it to have somebody out on the street, right? It's not just inhumane. It's a significant social problem for people, significant economic problem. If you look at our prison system, people say, oh, the overcrowding prison system is really, really bad. Well, it is really, really bad. And a third of the adults in that space have a diagnosable mental illness, right? And again, if they got their meds, if they got their counseling, if they got their treatment, they'd get better. 70% of young people, right? Anybody in here work in the court clinics with young people? So you will at some point, I promise you, because you can't avoid it, be called by a parent to say, will you come with my kid to the judge because he's wrong place, wrong time, nicest kid in the world. But the courts don't have resources to treat these kids. They can't send them someplace. They can't get them somewhere. So 70%, we have a de facto mental health system in the juvenile courts, right? Because 7 out of 10 of those kids have a diagnosable mental illness or substance abuse problem, right? Wrong place, wrong time, and a treatable, I want you to remember this, a treatable illness, right? A treatable illness. 4 out of 20 kids in a classroom have a diagnosable mental illness. So if a fifth of kids have mental illness, got a classroom like this, so this is a classroom with probably 40 people in it, so I got 5 people in this room probably that have a diagnosable mental illness, right? And I know I got half of you that'll have a mental illness at some point in your life because 50% of us get a mental illness at some point in our life. And 100% of you have somebody in your family that has one. I won't ask you to raise your hand, but you know we all have those people very close to us. But imagine a teacher with a class of 20 kids. That's not a bad class, actually, having been a high school teacher. 20, I was happy the years I got 20. 18 would be ideal, right? 25 is kind of outrageous if you're a 5th grade or a 6th grade teacher. 18 to 20 is all right, but 4 of your kids have ADHD, they've got anxiety disorders, they've got depression. So depression in boys, what's that look like? Doesn't look like morose and sad and sullen in boys. It looks like, let me punch, let me push, let me, right? So you got that kind of stuff. It's no wonder that large numbers in the first 5 years of their career of teachers leave the field. And they don't leave because all of a sudden they decided they didn't want to be a teacher. They leave because sitting with this disruptive environment, it's really hard. It's really hard. If you're looking for help in Massachusetts, Stan Berman, my academic vice president, carries cards in his pocket. I carry cards in my pocket from some dad or mom that we know that says, can you get somebody to take care of my kid, right? And why do they ask us? Because Stan's taught 1 million people. 500,000 people. Bro, he's not that old. 500,000 people. And he knows a bunch of folks that have been in the environment, right? And a call from Stan, which may take a week and a half to get connected to somebody, is likely to be efficacious. 70% of the time, a mom or a dad that wants to get mental health for their kid in Massachusetts cannot get it. They're not there, right? So you knock, full. And it's not even people who are limiting their insurances or whatever people do in a way that I would hope you would not when you grow up. But it's people that just say, I just have too many people. There's too many knocks on my door. I don't have enough time to be able to take care of the people. That 70% of the parents that want to get mental health for their kids in Massachusetts cannot. Massachusetts, right? This isn't the Midwest, and this isn't Iowa, right? This is Boston, right? This is Boston. Can't get care for their kids. With kids, it's not only about treating the kids, the 20% that have a mental illness, it's treating all of these kids, right? Because if you're a mom or a dad, if you've been a parent, you know that growing through school years is not about reading, writing, and arithmetic. It's about relationships. So I've got a little boy. My midlife crisis is 12. We had a discussion this morning because he has a lovely friend whom I've coached, whom we've had in our house many times, who we've taken on vacation with us, and we went to vacation. This is one of his best buds. He's an adopted kid. He's placed in the 6th grade. He was placed in the 2nd, 3rd, 4th grade when he came from Africa because they thought he was socially and emotionally at that level, and even academically he needed that help, right? So now he's 12. He's in a group of 12-year-olds, but he's 13 and a half. And his hormones are kicking in. And so my son said, I don't know what's up with Eob. I said, Eob, you want to come out? We're catching leaves when they fall down from the trees. It's like really cool. If you can grab them, you can make a wish on them, and it's really cool. And Eob looked disdainfully at his best friend and said, I'm not going to hang around with 6th graders anymore. Why are you talking to me so much, Peter? Right? Best friend. Like sleepover, best friends, right? My guy and this guy. So this guy's got to learn what's a friendship? How do you manage relationships? How do you deal with hormones as they're kicking into your body, right? How do you look at girls now for the first time? Because that's why he doesn't want to hang around with little boys. He wants to look at the girls. And he doesn't know beans about doing that yet at 13 years old, right? As most of us didn't. I didn't think I got that till I was 18 or 20. And it's arguably if I ever really got it. But it's a thing you got to learn, right? You got to learn how to make friends, how to talk to people, how to speak truth to power, right? How to be an advocate. So with Pete, I've got to find a way because I want to go wring Eob's neck for hurting my kid, right? So I got to think about how does the psychologist deal with this when he's not a dad, right? In some way. So I got to think, how do I get my son to write a good letter to Eob and say, I'm still your friend. I'm not a 6th grader. I'm your friend, and this hurt me. And you be who you want for as long as you want, and I'm not going to call your name in the thing, and I'm not going to ask you to do games. But when you're ready and you still want to be my friend, I'm here for you, right? Whatever that is. How do I govern myself? What are the good choices? How do I develop empathy? This is really important because not only do all of our kids have to grow through that, but it makes a difference of about 11 to 15% in achievement test scores, right? So if you can settle yourself, like if my little guy's not worried today about what Eob said to him on the thing, how do you think he's going to go into math with that worry on his mind, right? Or all week with that worry on his mind. So I don't have a kid with diagnosable attention deficit disorder. I got a kid that has a problem with his friend and a problem with his hurt feelings. But it's going to impact his math and his English and his science for the week, right? We have to be able to help kids with that, and we don't. But these folks that have studied this from the Castle group say we're past the point of knowing that this is important. We've got real danger in our growing and developing children because we don't help them learn how to manage their emotions, learn how to make friends, learn how to deal with older people, learn how to engage the world, as well as learn how to do reading, writing, and arithmetic. So they say it's reading, writing, arithmetic, and relationships, right? It's the 4th R that we have to help people with. So whether you go in as a school psychologist, a counseling person, as a mental health counselor, as a psychologist, as a parent, this is really important stuff, right? What the World Health Organization says is by 2020, childhood psychiatric disorders will be within the top 5 of the major causes of morbidity, mortality, and disability among children. So remember back, I think I had it there, around suicide. It's the 3rd most common cause of death for little ones, 8 to 15. It's the 2nd most common cause of death for adolescents. Suicide, right? Suicide. A totally preventable problem. A totally, absolutely preventable problem, right? We're not talking about head injuries, accidents, gunshots, cancer, heart disease, immune system problem. We're talking about suicide, right? How do we find our way to make sure that the kids that we are raising grow up with relationships vibrant enough, strong enough, and the ability to manage their emotions resiliently enough so that this is not the end, right? That's your job, younger people. That's your job. That's your job. That's your job. Vets. About a fifth to a third of the people that come back from war have said that they have a mental health problem, right? So anybody former military in the room? Okay. So when you muster out, they ask you, you have two choices. You can stay and fill out this thing and we'll talk to you more about it, or you can go home today after you've been deployed, right? What's your choice, right? Get on the bus or stay here? Well, let me think, right? So thank you for what you did. 20%, 30%, right, cop to it, and they say, so how much more is there, right, that people say, you know what, I'm not going to stay around and talk with you guys. I got a little kid at home, I want to go drink a beer. I got to go talk to my folks. I got to be someplace I got to get out of this uniform, right, someplace. Combat exposure is a risk factor. Strong social supports, like you would expect, is a mitigating factor. About half of the veterans that have a mental health have a mental health problem, want to get care, but most of them can't get it. And 75%, so this is important and rarely looked at because we're thinking a lot about evidence-based treatments and PTSD treatments and exposure treatments and stuff. And so we've been focusing for a while on, isn't it great we've got these techniques? Most people don't sit for the techniques. 75% of soldiers leave them. 3 visits, 4 visits, 5 visits. They don't. It doesn't work for them, right? They get a lot of trauma. Interesting to me, the trauma that they got was not killing people, which was the end small amount. It was watching people get killed as a soldier, right? Very debilitating, very traumatizing. It's something that most of us don't see unless you work in a hospital or you're a first responder. It's something you don't see, right? And the rates of depression among soldiers, 5 times as much as civilians, 6 times as much for intermittent explosive disorder, and 15 times, as you would expect, more than the general population for PTSD, right? So it's a significant group of people. The problem is this is the 1%, right? And it's the 1%. You see them handling it atrociously in the news these days. Last couple of days, atrociously in the news, politicizing the death of these 4 heroic people, right? It's 1% of the population that does what this doctor did. 1% of the population. So after the war's over, no one cares. No one asks. I grew up in the era of the Vietnam War. It was on our minds daily, every single day, till 1975, 1976, when that helicopter left Hanoi. No one talked about it at all for 10 years, and the vast majority of those soldiers lost their marriages. Vast majority of people who were married and soldiers in Vietnam did not keep their marriage. Why? Because the sequelae of war makes it very difficult for people to live with them and for them to live with themselves and for them to live with other people. And we didn't do anything for those folks. We can't keep doing that. We've got to do a lot better. They need it. Recent survey by the VA says the blue line down the bottom, major mental illness, is about the same. So schizophrenia, major affective disorder, in VA clinics, it's about the same. It's not rising, but boy, look at the rise in depression. Look at the rise in PTSD. Look at the rise in other anxiety disorders. This isn't getting better with the interventions that we've made. It's getting worse. If you are a child of a military family that's deployed, you're more likely to have, 5 times more likely to have behavioral health problems in the school than the kids that are not, that are also military. So I'm on the in Lincoln. They have the Air Force Base in Bedford. It's the only residential only residential base in the state, and they're talking about, well, they got all these kids with like special ed needs. They were talking about it. And I said, these aren't kids with special ed needs. These are little boys and girls who either live with the threat of their moms and dads being put into a theater of war or have a mom or a dad in the theater of war, and they're scared shitless. And they need our help. It's not about their need for special ed services. It's about a humane need to be able to bring what we've got that lets them do what they're going to do on our behalf that's sadly critically needed, right? 75% of families report that they have a lot of stress when they come back from war. Another area, a couple of important reports. If you haven't read the Surgeon General's report on mental health, race, and culture, Surgeon General Satcher is the first sitting Surgeon General in the United States to author, and he really did author these things. When you read them, it's got his voice in them. But real expert people did research to say, what's the state of mental health in the country, and what's the state of racial mental health in this country? Institute of Medicine has an excellent report on unequal treatment. And George Bush did a great job with his New Freedom Commission. If you're in the field, you ought to read these books. They anchor us, they center us about mental health and race and ethnicity especially. So surveys find people of color in our country, they actually have less mental illness than Caucasians, non-Latino Caucasians. But the problem is they have more persistent and more severe mental illness than I have, right, in my life. Why is that? It's because
they probably don't come for service.
It's because they don't come for service.
They're unreported.
And because when they come for service, they meet someone that looks like me for service, and they stop coming after one visit and go someplace else, right? Or they can't get services, or when they get services, people say, so here's the thing also true for kids, 75%, as I mentioned, of Caucasian kids, non-Latino Caucasian kids, they can't get service. But if you start to look down the line, Latino really hard, 88%, Native Americans, Pacific Islanders, really, really, really hard to find care for those kids. So what's the problem with access to care? Big problems. People go into healthcare systems as a person of color, and big surprise, it's no different than going to the supermarket. They meet somebody with an attitude, even if it's somebody that has a license. They meet somebody with prejudice in their heart and in their mind, and they meet, it seems, people who give inadequate protocols for the treatment of folks. They also meet people who are more inclined to say, if this kid is acting up in class and he's a white kid, probably they get what? ADHD, right? Happens a lot. If this kid's acting up, having fights, squirrely, difficult, pulling stuff, and it's a brown or a black kid, what do they get?
ODD.
Yeah. Right? So everybody knows ODD, right? Bad kid syndrome, right? Bad kid syndrome. And it puts these kids on a path where they then interact with people, not as a kid that has a need that we can help with because we have treatments that work, but it's a kid with a character problem, right? Because they're mad at this kid for having the character problem. And because in the world also of education, most of the people are white, and they don't have advocates that say, gee, the book says this is likely to happen. Are we sure this kid has ODD, or is this kid maybe got a ADD, ADHD problem? Let's test the kid, for God's sakes, before we start making this stuff right. But because we don't have leadership of color, about 5% of psychologists are black. Right? Again, most of psychologists look like us in the room, white folks in the room. Because that's the case, then there's no advocacy for this. There's no dialogue about this. I watched the other day, we have a lovely man we just hired to do our undergraduate program, and we had 200 and some odd kids in the room, and their teachers and coaches in the room. So imagine that if you're the guy that has to take care of the rug, right? That was a difficult, because they had lunch and they're spilling stuff, but they were here, like lively. So I talked about the importance of bringing people of color into the field, and there's one or two folks. There was a judge in the room I had interviewed. I knew him kind of. There was a couple of coaches in the room, athletic coaches that I knew in the room. They knew and most of the kids in the room saying, white guy talking about stuff. Is he okay? I don't know. Maybe yes, maybe not. Mark, who's an African American, gets up to talk. Former school teacher gets up to talk. All these kids, they're like engaged. This is my brother, this is my father, this is my uncle, this is my family member, this is somebody, right? We need to find a way in mental health care to bring folks to this, because all of us need this, not just the kids that we're going to meet. We all need to have our sensibilities recalibrated, and that's an everyday event. That's an everyday event. Some things that these reports suggest: increase the awareness of disparities in mental health care. So if you're a professor teaching about this, find a way to bring it into no matter what you do. It's really that important. If you're doing brain behavior stuff, it's there, right, for us to look at. If you're a student, please read those books. It's really important. We want to make sure that we're attracting and supporting self-identified persons into psychology. We have $800,000 in scholarship money we put away. We're a little tiny place. We're not a Boston college with a lot of money. But we want to attract and support people of color into the field because it's critically important we do that at least for the next 5 or 6 years, right, to do. And as we've done that, our faculty have grown. So it's funny, you know, if you're sitting in a room, as I did at the BI, how are we going to get black and brown people and Asian people to come into the Bethany? Well, they never do, right? They never do. Run a program like this and people start to come. So we're about 30% now, this building, of faculty and staff who are persons of color because we built it and people came, right? Think about finding an ombuds person in your space, because if you're in a school or if you're a kid and you're dealing with people of color, you can predictably understand that there's going to be problems in that space, no matter how we want to have that in this space, even with the changes that we're making, because people have to have somebody they can go to that they can trust. And it can't be the HR people, it can't be the Title IX person, it can't be another white guy. It needs to be somebody that they know that they can get a respectful and affirming response from. We need to build that out as a resource. And we also need to include multicultural subjects in evidence-based treatment research. If you look at the things that people research, it's mostly, again, college sophomores, and college sophomores are mostly non-Latino white kids. And the principal investigators are college professors, and we are mostly non-Latino white people, right, men or women. All right, so here's a graphic, but a pretty important graphic, right? 90%, Annapolis Coalition study, big study on workforce in mental health. That's what it looks like if you're somebody coming in for mental health and you're a person of color. You're going to meet those guys, right? You're not going to meet the guy in the middle 10% of the time. All right. Let me tell you a little bit about medicine, which is something many people are not working with. So there's the doctor said to Mrs. Cow, you know that ringing in your ears? I think we can help with that, right? So there are things that psychology can do in medicine that no one's asking for us to do yet. They know they need them, but they're not part of the current culture in a rich and complex enough way. Someone like Stan worked as a psychologist at the Dana-Farber Cancer Institute with little kids for many years, because a little kid with cancer has brothers and sisters that are living with cancer, has a mom or a dad that are living with cancer. Like, the whole family needs to talk about this tragic experience that's visiting them. Most of the time it gets better, but for the 18 months, a year, 2 years, or the repetitive illnesses that come back, it's the worst thing that can happen in your family. It dominates everything, and people need to learn how to cope with that, and they need to be connected to other people to do that, to be able to survive it, right? So what? 50% of behavioral health is delivered in primary care. So if you think about the treatment of depression, anxiety, right? If you think about the prescription for medications, half to 3/4 of the psychotropic drugs are not prescribed by psychiatrists or psychiatric nurse practitioners. They're prescribed by the primary care doctor. And she's doing Prozac, and she's doing Pickett, right? That's what she's doing. Is she referring for counseling? Almost never. Half the time would be good, right? Almost never. Let me try this, see if it works. Let me try that, see if it works. She has the same problem that Stan and I have, right? She doesn't know anybody either that can see these families with this kid. And she has 15 minutes to make that intervention work. 15 minutes. Then she has to go do somebody else, right? So 20% of primary care patients have anxiety, depression, or substance abuse. It's a big deal, right? So if you think you got 100 patients, you got 50 patients in a day, right? 10 of those people that you're going to see are going to have diagnosable mental illness, right? And probably people would argue a third of those people that you're going to see have diagnosable mental illness. It's again a de facto delivery system for mental health care that people are doing without any training. These guys took a semester, like one little rotation, maybe 3 months, 2 months in psychiatry, and that's it. That's all they did, right? That's all they did. Depression with chronic illness is enormous. Pick the illness, it gets worse, from 11% of people with Alzheimer's to what's that say, 42% of people with cancer. If you've got diabetes, it costs 17 times more to take care of you if you have depression than it does if you don't, because you don't take your meds, you're not motivated to lose weight, you don't go to your appointments, you don't follow the doctor's orders, right? If you've got, who cares? I don't care. I feel horrible. I feel awful. Don't you understand, right, that I have that? And again, 7 out of 10 times, we've got something that'll fix that, or at least will attenuate it in some way, will moderate it, and modify it in some way. But it goes untreated, and it winds up being a problem. Because anxiety and arousal are cognitively mediated, meaning you got to think about the world, perceive the world in a certain way, and it's your perception that matters. So I tell people, if you get divorced, or if you have a new baby, either of them could be the best or the worst day of your life. Pick it, right? It's your perspective that matters. If you look at the world and you see danger, your autonomic nervous system gets aroused. If you look at the world and you see, you know what, I can't wait for that big fat fastball to come down the middle of the plate because I'm going to hit that sucker out of the park, right? As opposed to, oh God, I saw him being the last 2 guys and he's really brushing people back and I like to stay close to the plate. What if I get hit in the temple, right, and die, right? Very different type of at-bat for somebody. So you can't wish that on the Yankees no matter what. Let me just say. No matter how you feel, you can't wish that on the Yankees. But there's a lot of problems. I'll tell you about a couple. But, you know, asthma is a problem of anxiety. 20% have it. Insomnia is a problem. Almost all of anxiety. Diabetes is a significant problem. Irritable bowel syndrome, hypertension, non-cardiac chest pain. 20% of the folks complaining of chest pain that look just like me that are in the emergency room are going to be admitted overnight because I'm overweight and I have high blood pressure and I've got a chest pain. But what if it's anxiety, which it'll be 1/5 of the time, right? I'm going to take up a bed, take up $1 million workup unnecessarily. And by the way, again, if I haven't said it, we got things that fix that. We got interventions that can fix that. You've got a little poo bear and the doctor says, you know, I think I have to talk with you about your sugar intake. The doctor at the bottom saying, you know, let's think about it. What's worse, exercising for 20 minutes or being dead for 24 hours a day? You pick it, right? Asthma is a significant problem. It affects a lot of adults and a lot of kids, a lot of emergency ward visits. Up to 1/3 of children with asthma have anxiety. If you look at surveys like Hassler did, if you have childhood asthma as a kid, you're 4 times more likely to develop an anxiety disorder than the normal population as an adult. And if you have if you have an anxiety disorder as a kid, you're more likely to develop asthma as an adult. Right? You know the thing, perceiving the threat, increasing your awareness of interoceptive cues, mean how am I breathing, how am I holding my body, and so forth. Increased autonomic nervous system reactivity, hyperventilation, and panic. All of that stuff strains the drive to breathe, strains the already hyperreactive airways, and causes asthma. Right? Insomnia, similar problem. It's the second most common complaint that people bring to primary care today. So every other patient, maybe, today I'm going to see is a primary care doctor. They're going to tell me I can't sleep at night. 65 million people suffer from it. So there's Charlie Brown. He says, sometimes I lie awake at night and I ask, where have I gone wrong? And then a voice says to me, I think this is going to take more than one night, right, to answer. A lot of studies, there's now several hundred studies about this, but I picked Jacobs because it's nice and clean. It says a couple of things. CBT for insomnia does better than the drugs do, and even better than CBT and the drugs at 6 months, because most people don't take the drugs, right, when they're in the treatment. But it's really helpful for people to feel a sense of mastery over a problem like this. And at 6 months, they feel like, I conquered this. I've got empowerment around this. I know how to calm and quiet myself at night, and I use that because I've learned a skill as opposed to a drug helped me to affect this. What am I going to do if I get into a space where I don't have the drug? A couple quick things, and then we'll take some questions. Substance abuse, a similar problem. Very common. 1 in 7 people are going to have a substance abuse disorder. That's about 8 million adults who also have mental illness and a substance abuse problem co-occurring. About a third of those people are the population of people with a drug abuse, so that's about 3 times more folks that get it. We've got an opioid epidemic that takes 12 million people. We know this, and if you look at the figure at the bottom, it shows that the folks with anxiety that are folks with drug abuse problems are much more common than the people in the general population that have anxiety, meaning what? Meaning what we all have taught and thought. There's tons of people that need our help, tons of people that need our help. This is an area with great need, considerable need that we've got to fill. Big shortages. 18% of substance abuse counselors turn over every single year because the work is challenging, difficult, and they don't pay them terribly well. Psychologists, we're 55 years old, are we? And psychiatrists, they say, our average age of 57 and 46% are over 65. So somebody in here is better at math than I am. So that must mean that to get a 55 out of 40% over 65, they got to have a bunch of 12-year-old psychiatrists in that group, I think, somehow, to get that, right? So anyway, the point is, there's a great need, there's a great opportunity, there's openings, and there's great mental health shortage areas. And the point to a group of faculty as well as students that what we do about this is yours. So I got a job, I'm doing my job. Stan's got a job, he's doing his job. We've got Patty's got a job, Joe's got a job. We're doing our job trying to say this. But this is a problem that really needs all of us to speak up for. This is a problem that needs tremendous advocacy. This is a problem that needs people to come into the field. This is a problem, I promise you, and you can talk to the people that do this, right? Don't you love doing what you do? Like every day that I got up and I meet people, it's like reading a novel. And I've met hundreds of people now. I don't see so many patients anymore. But over the course of my life, for several years, that's all I did was see patients all day, every day, hour after hour, right? But it's a wonderful experience to be part of somebody's journey. It's even more rewarding than being a teacher for students, I think, because that journey is deep and profound and intimate and engaging for a long period of time. So I'd like you to think very hard about that. And if you're a teacher, even in a related field, right, in the neuroscience area, encourage your folks to be thinking about this. Not everybody's going to be a neuroscientist, right? We need people to be a clinician. But a lot of people, 65, they say, let me get out of this thing that I'm doing. I hated it. For years, and a ton of people stay in this field. How many people in the room over 65, right? And liking what we're doing, right? And liking what we're doing, right? Liking what we're doing. So that's a good sign for a young person, right? If you've got older people that still like what they're doing and they're still in it with enthusiasm like this, makes for a good field. I'm pretty accessible. Students, if you want to write me an email and say, I wanted to learn more about this, can you send me something? I deliberately didn't litter this with a lot of references. This is an easily accessible literature, but my hope is that you can see from looking at this acre of land, there's a ton of this work for us to do. All right, so thank you all very much.